TopMedTalk.
Well, hello and welcome to TopMedTalk. We're in Denver, Colorado for the Society of Obstetrical Anesthesia and Perinatology, or SOAP. I'm Desiree, Chappell, co-editor-in-chief and host of TopMedTalk, and joining me today is the founder and former editor-in-chief of TopMedTalk, Monty Mythen. Just allowed you back.
It's always good to be here. Always good to be here.
It is. I feel like we're getting back to our roots today.
We are getting back to our roots.
Yeah.
Pointed out, founded it. You did. Then you joined me fairly soon afterwards and became the co-editor-in-chief. And then a few months ago, I had to step down from co-editor-in-chief because I joined Edwards Life Sciences as an employee, as effectively the sort of chief medical officer. It's not called that, but that's what it's like.
Yeah.
And they're also a sponsor of TopMedTalk. So too many potential conflicts of interest there. So I fell on my sword.
You did. your own sword.
And the wonderful Professor Mike Grocott took over.
That's right. Yeah, we've welcomed Mike and excited that he is part of it. But it's always good to have you back.
Good to be.
And we are here at the SOAP meeting. This is a fantastic meeting, isn't it?
It's great. It's one of these sort of smaller meetings.
Yeah, although it's pretty large.
It's pretty large, but it's mainly the plenary single auditorium, the conflicts of interest, we listened to the NAP7 recording earlier on today. I think you're doing a podcast. You're into it.
We are.
New Lucas in the next few days, I think.
We are. Yep.
And, the room was packed.
Yeah.
It felt like thousands of people in there.
Yeah.
It was quite hundreds or so.
Hundreds, sure.
But everyone concentrating, everyone in one room, and then the networking is excellent. Met lots and lots of old friends and young old friends as well.
Yeah. Younger friends too. Well, me too. So I've seen some friends of the TopMedTalk family. Yes. People have been stopping by to say hello, previous guests and listeners. People have been participating in our EBPOM meetings in the past, which is fantastic. EBPOM, Evidence-Based Perioperative Medicine.
Which we are the broadcasting arm of that. That's how TopMedTalk started.
Yeah, absolutely. So, but one of my friends was walking right by the booth, and it was like shouting, I can't believe you're here. So it's wonderful to be able to see friends that we've had over the years in different guises and different parts of our lives. And today we have Cheryl Parker, who is now the University of Louisville Nurse Anesthesia program, which is fairly new. I think they're just had their first cohort start this last year. She's the program director for that program. Cheryl, thank you so much for joining us.
Oh, thank you for asking me. My pleasure. I was very excited to see you. I think I might have squealed a little bit.
Well, Cheryl, I say we're longtime friends, and we actually met really in the obstetrical space, didn't we?
We did.
Yeah.
We were finishing up our training right around about the same time, and in OB for that last leg of our nurse anesthesia training. And,
it's been a while, maybe not quite as long as Monty's known some of his friends, but but Cheryl, you actually went straight into obstetrical anesthesia, and that's the primary anesthesia that you've been practicing over the years, isn't it?
That's right. I actually started out my nursing career as a labor and delivery nurse, and so obstetric care and women's health has been a passion of mine for a very long time, 30 years. So
for a little bit,
literally 30 years. And then had the opportunity to go to nurse anesthesia training with the help and support of the anesthesia group. And then, of course, they offered me my dream job to come back and be a obstetric nurse anesthetist. And I absolutely accepted that offer.
Yeah.
So if we could do some global decoding.
Oh, yes. Thank you for translating.
I'll do a transatlantic decode first. So a labour and delivery nurse. Now, in the UK, we have midwives.
Right.
I don't know if you've seen the programme.
Yes.
Quite popular.
I love that. It's my favourite TV show.
They're the equivalent. They're equivalent, are they? Midwives and labour and delivery nurses.
In the United States, a midwife actually will deliver the baby. I think from watching the BBC program, The Nurse Midwife. Yes, I think when we moved obstetric care into the hospital realm, then we created this new position of a labor and delivery nurse, which just provides intrapartum care, addresses the patient's needs, monitors the labor process, but doesn't actually deliver the baby.
Who delivers the baby?
Well, now
half of the mum does usually.
Right, yeah, she's usually the one. So we do have nurse midwives who will deliver the baby in some instances, or a physician obstetrician.
Gotcha.
So, yeah.
Those are the differences. And then I think we all understand because of Desiree now what a nurse anesthetist is.
Anesthetist, but
anesthetist, whatever.
Yeah.
I'm working in it.
Yes.
So that meant then when you went back in that role, what was your extended roles then? You did in the labour and delivery suite.
So,
or the operating room.
Right. So, and I think, I'm sure you've clarified that to become a nurse anesthetist, you have to go have that ICU level training. So I actually left the OB arena for a couple of years, got that high level acute care training, then entered school for another 2 years to learn how to administer anesthesia. And then I came back and my new role was to place epidurals, spinals, provide any type of intrapartum pain management. So anything from heavier IV sedation all the way up to general anesthetic.
And if a C-section, emergency C-section in the operating room converts to a GA, for example, you're allowed to follow that all the way through. The word allowed sounds a bit strong, but in some parts of the world, we're still traveling a journey away from non-physician anesthesia providers being the monopoly providers.
Exactly.
So the allowed bit sounds a bit...
Sure.
You know what I mean, though?
I do know what you mean. So in the state of Kentucky, we are what we call an opt-out state. So the abridged version of what that means is that nurse anesthetists have full scope of practice, and they often practice independently. So yes, in the environment that I work in, I have full scope of practice and can do any type of anesthesia under any circumstances.
Yeah.
I'll hand back to Desiree in a second now, because we were discussing over lunch, we popped out for a quick bite to eat, the fact that we were just about to miss a session called TIC.
Yes.
And I couldn't work out from the title of it, because it was to do with trauma-informed care.
Right.
What it meant, but I think you've discovered that.
We did. So we were talking, so Cheryl and I were just catching up and talking about the meeting, which, by the way, has been phenomenal so far, and it's only been going on for
half a day. It is. It's incredible.
Yeah. Is this your first SOAP meeting that you've been to? Yeah, I was going to say, I just think so. Yeah.
I think this is my fifth SOAP meeting.
Yeah. So lots of wonderful information. But we were talking about one of the sessions in particular was, like Monty said, entitled TIC, Trauma-Informed Care. I was not familiar with that terminology either. So tell us just a little bit more about what that means. And you've had some experience in this space.
Trauma-informed care means that providers who are providing any type of patient care service should be aware and conscientious of the patient's previously suffered trauma and provide care with the intentionality to avoid re-traumatizing the patient.
So this doesn't necessarily, it's not specific to obstetrical anesthesia or obstetric care.
No, but it plays a very significant role in our world when we consider the fact that women on the grand scale, based on studies over the last 10 to 20 years, are showing that 1 in 3 women have suffered significant physical or sexual trauma in their lifetime, and then can frequently be re-traumatized during the birth experience.
What is 1 in 3?
1 in 3. Yeah.
So I'm guessing it's part of our standard history then when we do our prenatal evaluation these days?
Not yet, but that was a big takeaway from the presentation, the TIC presentation that just happened an hour ago, was that we need to consider adding that to part of our pre-op and prenatal evaluations for patients.
Yeah, so that was Tracy Vogel that was giving that presentation and had some other types of recommendations, didn't she, that she was talking about that you said that was interesting to you?
Yes, I was just, I guess, delighted, if you will, to hear some of these recommendations. I personally had experience with a patient 12 to 15 years ago, came in, and it was a patient who had suffered significant trauma. And at that point in time, we didn't really understand a lot about trauma-informed care or birth trauma. And so the recommendation that Tracy made was we need to slow things down in the OR, and we need to be respectful of the patient as much as we possibly can. And as hard as it is for anesthetists, but hand over some control to them. The recommendation that really resonated with me was she suggested that when we, in a controlled circumstance, take the patient into the operating room, we should allow for as much modesty and privacy in that moment and reassuring the patient as well that the block that we just put in is working. So controlling that OR environment so that there is only the anesthetist, the patient, and possibly, and strongly recommended, a support person with her support person.
Yeah.
Those 3 individuals in the operating room and no one else.
Wow.
Until after we're sure the block is working and the patient is draped.
So I'm guessing there's some fairly reproducible triggers, of which a lot of them are hard to avoid in childbirth.
Yes.
Want to touch on a few of those?
So my experience with my patient, she was an amazing patient because she taught me so much about trauma and care after trauma. And when she came to us, like I said, she was very knowledgeable about her situation. So she told us up front, which you don't usually hear this. I was raped. I suffered a very traumatic rape at the age of 18. And then at the age of 34, when I delivered my first baby, I experienced a re-traumatization from the epidural experience specifically, and then the placement of a Foley catheter. Those things made me feel that I was back in that situation.
Yeah.
And it's the matter of being exposed when against your will, and then a heavy epidural and not being able to move, and then having people touching you and doing things to you, and you feel paralyzed, or held down, as she described it. So when she told me her story, I agreed to have her partner was sitting in the room with us. He sat in front of her and held her hands while I placed the epidural. She didn't want to take her clothes off, so I said, no problem.
Yeah.
We'll just, make it space on your back. So she was in her own clothes, which was her preference. She had a support person in the room, which is her preference. And then when it came time to put the Foley catheter in, she really tried hard and to allow the nurse the first attempt, and then called a stop to that process. And
because I guess the same for all of us as clinicians. The first time that we went to the labour and delivery suite as a youngster, and we suddenly saw this woman stripped bare and do as I say, and legs up, etc., etc. It seemed, I think back to it, it seemed brutal. It seemed completely outrageously brutal. Move forward a few years and you're completely numb to it. You're not in a non-caring way. You just think it's normal to have a whole load of people in the room staring between a naked lady's legs.
Right.
And it's just not.
It's not.
Yeah, be the naked lady.
Right. And I think, we probably, as women, Desiree, you've had children, I've had children. I actually had a child at the age of 17. And so there were 2 ways to handle that. You either try to find some way to make fun of the whole situation so that it seemed less traumatizing, or you dissociate completely from it. But the thing about childbirth is we remember the story every year. Every year that our child has a birthday, we're like, oh, I remember this day, and I remember it was 2:32 a.m. when my child was born. We know the exact time. And so when we unfortunately have a very traumatic event, then this is what Tracy Vogel talks about, is now this becomes an annual re-traumatizing because they remember this experience. So the recommendation is, let's do better about really creating a positive experience through trauma-informed care.
Yeah. I think what you said, we were talking about this before we started recording, is just to be aware of this. I've learned so much just with my own patients that are not obstetrical patients, to kind of talking about these types of things. We've all taken care of patients that are somewhat hysterical whenever they come in, and it finds out that it's because they had some sort of trauma or something in the past. So I think we can all learn a lot. But it sounds like in the space of obstetrical anesthesia and just obstetrical care in general, that this is something that we're really taking on to try and help, like you said, do better.
Yes. I think patients are more empowered now, and they're talking more about this.
And informed, it just sounds.
Very much informed, and asking, they're starting to ask why. Why does it have to be this way? And why can't I, much like the patient that I had, why do I have to take my clothes off and put that gown on for an epidural,
And trauma-informed care, or TIC as it was referred to, Is that now nationally in the USA recognized? So there's mass recognition of what people are talking about? Because I'm ashamed by the fact that I had to say, I didn't know where we were coming from. It's an ex-trauma SICU doc in a different thing, car crashes, smashes, etc., or PTSD type of environments. I'm thinking, where are we going with this?
Right. I don't, I wish I could say what the level of knowledge is across the country. I started hearing about trauma-informed care. The first professional organization was at A1 about 3 years ago.
At A1, what is A1?
A1 is the Association of Women's Health Obstetric and Neonatal Nurses. And it is the professional organization for perinatology nurses. So they started talking about it a little bit a few years ago, where I heard, that's the first time I heard about it at that level. When I took care of the patient, that I had the opportunity to care for 15 years ago, I didn't know what it was, and we didn't call it trauma-informed care. She had a different name for it, but I was thrilled that, here at this level meeting, that there have been multiple conversations about trauma-informed care since I've been here today.
Yeah.
So the first challenge, and it may already exist globally as a term that people recognize, but if it doesn't, I think it would be great if it was as soon as possible.
Absolutely.
So we all know what we're talking about.
Yeah.
That, it's okay as a patient to speak up and say, you know what, it may seem a little bit crazy to you, but this is something that really, really matters to me. Yeah, it's not to belittle, being raped in the past, but they come in very many different guises.
Absolutely.
I really don't want you to uncover this bit for reasons that are very personal to me.
Right. Not to focus on just the one example that I gave, but another example that Tracy talked about was unmanaged pain, which is dear to our hearts as anesthetists, right? So, and there are a lot of instances in the obstetric world where the pain is unaddressed or unmanaged. You think about a failed block when we take a labor epidural to C-section, and she doesn't have adequate pain during that C-section, and then we have to convert that to either a very heavy sedation, which wipes out the complete memories of the birth, or to general anesthesia. So there are a lot of instances that, and so that first experience then leads to, maybe I don't want to have another child because I don't want to experience that again,
For sure. Cheryl, it is so wonderful to talk to you. I'm so glad that you walked past.
I'm very glad I walked past you.
It's great. Well, lots to talk about. Like I said, we're super excited to be here. This is our first true obstetrical meeting in this specialty. I think Monty and I both have been talking a lot about wanting to get here, and so we're excited to learn more about sharing the knowledge that is shared throughout this meeting. So, but just thanks for being our first guest.
Oh, that's been my pleasure.
Very nice.
And a shout out to
JHB, baby, Jennifer Hart Bates. She's our favorite, dear friend of ours, a nurse anesthetist who is at the University of Louisville as well. And I've had the privilege and honor to work with her over the years at my site. She has taught me so much, and she is just a force within our space. And we love you, JHB.
Yes, Sharon. Wow. Yes, and can't have her back.
I know. Shout out to the University of Louisville and all the great work you guys are doing there.
Thank you.
A newer program. And wish you guys all the success in the world.
Thank you very much.
Maybe we'll have you back on to talk to you in a couple of years about how things are going for your graduating class.
August 2026.
All right. There we go. All right. And thanks for listening to TopMedTalk. You can always find us at TopMedTalk.com. We have an app with all of our fantastic content there that you can easily search for topics like obstetrics. We have had previous conversations at other meetings with SOAP folks, as well as things like enhanced recovery, all kinds of different things. So check us out. We're on social media. Like us, send us a message. We love that. We're on YouTube now, aren't we, Monty? It's been a lot of fun.
A revelation.
It has been. We're kind of dabbling in that just a little bit. So if you run across us on YouTube, give us a thumbs up and subscribe to the Top Med Talk channel. Thanks for listening. You're going to hear more from us over the next several days. Cheers, everybody.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.